the COPD in today's evening lecture. So about the gold guidelines, because we study the COPD by the gold guidelines, and there are changes in the gold guidelines of 2023 that it is a heterogeneous lung condition characterized by chronic respiratory symptoms such as dyspnea, cough, expectoration with the exacerbations due to abnormalities of the airways and the alveoli. If we have the involvement of the alveoli, then it is an emphysema. We have two parts, the bronchitis and the emphysema, that cause persistent, often progressive airflow obstruction. This is very important line, that the airflow limitation is always progressive and there is a airflow obstruction. The airflow limitation is usually progressive and is associated with an abnormal inflammatory response of the lungs to the noxious particles or gases or the biomass fuel smoke. So quickly summing up the definition of two terminologies, that is chronic bronchitis. Chronic bronchitis is defined as a chronic productive cough for 3 months in which of 2 successive years in a patient in whom other causes of chronic cough have been excluded. So any patient giving a history of cough for 3 months for 2 years, consecutive years, that goes in the diagnosis of chronic bronchitis. So in emphysema, there is an abnormal and permanent enlargement of the air spaces distal to the terminal bronchioles. That is very important, that the air spaces terminal to the terminal bronchioles will be involved and there will be destruction. If there will be no destruction, then we will label it as a hyperinflation. In emphysema, the destruction is very, very important to define as emphysema. Otherwise, it will be a hyperinflation of the lung without obvious fibrosis. So, the epidemiology about the COPD, this is the third leading cause of death worldwide and contributes 5% of the death globally. Globally, there are around 3 million deaths annually due to the COPD. The global prevalence of COPD is 10.3%, with the overall prevalence of COPD of 11.8 for men and 8.5 for the females. The prevalence of COPD in India varies from 2.5 to 10%. The causes 8.7 of total death in India and contributing to 4.8 of Delhi. Therefore, COPD is very important to understand, to diagnose and to treat COPD at the earliest, because most of the OPDs, we have the patient of COPD because smoking and the use of biomass fuel is very common in India and in the world. So a short about the pathophysiology of the COPD. We are starting from the left-hand side upper part. We have a bronchial and the bronchial injury is there, due to which there is a bronchospasm, there is a hypersecretion is there, and the infection is there. So we have a reversible obstruction in the bronchioles and the small bronchi. And if this continues and there is a repeated injury due to the smoking or by the repeated infection, the patient can land into the chronic bronchitis. And on the other right hand side, if there is a destruction of the alveolar walls due to the smoking or by the biomass fuel, there is a respiratory infection, the patient can land into the emphysema. Earlier, there were two terms, a blue blotter and a pink puffer. Blue blotter was used for chronic bronchitis and pink puffer for the emphysema. Now we have a different classification after the gold guidelines. We are not using the old terms, a blue blotter and a pink puffer. Lavanya, it's clear to you?
Yes, sir.
Lavanya?
Yes, sir. It is clear.
Okay. So this is the diagrammatic picture of the normal bronchi on the left side, and on the right hand side when the bronchi are constricted and there is a secretion of the mucus. When the mucus plugs the bronchi, there is a sound of wheezing is there. The patient is at distress. He feels uneasy and there is a respiratory problem in the patient. This is the about the diagrammatic picture. It happens inside the body also. So by diagram, we are showing that the disease part is the bronchitis. Now what comes that there is a pulmonary gas exchange abnormalities are there. As you all know that there are structural abnormalities in the airways, the lung parenchyma and the pulmonary circulation are altered. There is a normal ventilation and perfusion distribution is there. So due to the structural changes and by damage of the lung parenchyma and the circulation, the ventilation perfusion is mismatched, so the gaseous exchange will not be proper. So we are encountering lot of problems. This result in abnormal gas exchange leading to arterial hypoxemia with or without hypercapnia. Sometimes in the earlier phase, the patient may go into the uh, type 1 failure, then he can go into the type 2 failure. Emphysema also lead to decreased lung diffusion capacity. We can measure the diffusion lung capacity by DLCO. Now the pulmonary vascular changes, the intimal hyperplasia is there, and the smooth muscle hypertrophy is thought to be due to chronic hypoxic vasoconstriction is there, or the small pulmonary arteries leading to pulmonary hypertension. As we all know, when there is an infection, there is a bronchospasm, there is an increase in the pressure of the pulmonary artery is constricted, and there is an increase in the pulmonary arterial pressure is increased. The emphysema can lead to the loss of associated areas of the pulmonary capillary bed, and there is pruning of the distal vasculature. Progressive pulmonary hypertension may lead to the right ventricular hypertrophy and eventually the right heart failure. That we call it as a cor pulmonale. We in the COPD we have a right ventricular, there is a hypertrophy is there. So the right ventricle is dilated and the patient goes into the cor pulmonale. When we will define it as a exacerbation of the COPD, the exacerbation is defined as acute events characterized by increase or worsening of the respiratory symptoms. There is increase in the dyspnea, cough will be copious, the consistency of the cough will change, the color of the sputum will change, the volume will change, and the patient will have fever. triggered by different factors like respiratory infections with bacterial or the viral or the environmental pollutants, and the unknown factors, the pulmonary and the heart failure and the pneumonia can occur. During exacerbation, there is increased airway and systemic inflammation, increased air trapping is there, hyperinflation is there, the ventilation perfusion abnormalities are there, resulting in the arterial hypoxemia with or without hypercapnia. Then we will call it as a multimorbidity. Patients suffer from concomitant chronic comorbidities. Airflow obstruction affect cardiac function and initiate ischemic heart disease. Heart failure will be there because of the lack of oxygenation. Inflammatory mediators contribute or worsen. Skeletal muscle wasting is there, cachexia is there, there is osteoporosis, normocytic anemia, diabetes will be there. I will tell you why the patient of emphysema, they are lean and thin. Because the work of breathing is more in the patient of emphysema, and because of the low and flat diaphragm, they will be having always a feeling of fullness. There will be irritability due to the drugs, and he is depressed. That is why, and there is increase in the catecholamines levels. So you will find that the patient of emphysema, they will be very lean and thin. They will be lean and thin because of all these factors. Coming to the genetic factors, we have a, if the patient is having a alpha-1 antitrypsin deficiency, this is a genetically determined COPD is there. The alpha-1 antitrypsin deficiency will give rise to severe form of emphysema that can occur in the young age. COPD due to abnormal lung development, if the patient is having a low birth weight or a premature birth weight, then the chances of development of COPD will be higher in the later period of life. The environmental COPD, such as cigarette smoking, exposure to tobacco smoke, passive smoking, e-cigarettes, cannabis will lead to the environmental COPD. Biomass and the pollution exposure will also lead to the chances of COPD. If the patient is having a childhood infections, such as patient having tuberculosis in the childhood or the repeated viral infections, the chances of COPD are very common. If there is a long-standing asthma, the patient can have an overlapping of COPD and bronchial asthma will be there.